Electrical stimulation has been found to be beneficial when treating patients with neurological injuries. In addition, functional orthotics and bracing is also an effective treatment tool as well. In this next section, we're going to discuss the reciprocal EMG-triggered stimulation, also known as RETS, application combined with functional dynamic orthotics, and how the two can work well together when treating patients with moderately to severely impaired neurological injuries. Applying electrical stimulation to a mildly affected neurological patient or an acute stroke survivor can be very rewarding. When you apply the electrical stimulation to the appropriate muscles, you often get the desired response. However, with patients that exhibit increased tone and soft tissue shortening, it can be frustrating and difficult to generate an adequate motor response with stimulation alone. Oftentimes, the clinician will be required to manually assist the affected limb or use mechanical force such as braces and splints, in addition to the stimulation, to receive the desired movement. For example, do these videos look familiar? These are moderately to severely affected neurological patients with increased tone and soft tissue shortening. The wrist and fingers are receiving stimulation. Instead of getting the desired response, which is wrist extension plus finger extension, they're only getting wrist extension followed by finger flexion. This mimics a tenodesis-like effect. If these clients were mildly affected, the chances are you would receive wrist and finger extension during electrical stimulation. In this situation, because of tone and soft tissue shortening, this result is not achieved. Therefore, you would need to consider something other than stimulation alone to get the desired response. Let's now look at how combining orthotics and stimulation can be effective for the neurological population. The video on the left shows a moderately to severely impaired patient with tone and soft tissue shortening. When the stim is delivered to the wrist and finger extensors, the wrist extends, however, the fingers remain in a flexed position. With the video on the right, you see the same patient with stimulation in addition to the saboflex. As the patient grabs the ball, transfers it to the yellow tube, and relaxes, stimulation is delivered to the finger extensors. In addition to the wrist remaining in a functional position, which is extension, the fingers also will fully extend, putting the wrist and fingers in a biomechanical advantage for functional grasp and release. So with this mechanical assist, in addition to stimulation, the patient is put in the best position possible for functional grasp and release activities. Here's a video example showing a client using stimulation with and without the saboflex. The top video illustrates when the stimulation occurs to the wrist and finger extensors. The movement that is generated comes from the wrist with the fingers remaining in a flexed position. And again, that's due to tone and soft tissue shortening. The bottom video shows that the very same patient with stimulation and the saboflex on. As the patient goes to grasp and releases the ball, the spring assists in opening up the fingers while the stimulation occurs. So you're seeing more of an adequate opening of the hand and extension of the fingers. Using the saboflex with the stimulation will assist in giving the patient better biomechanical advantage. It will also help with the length-tension relationship when receiving the stimulation. Finally, using the RETS program with Sabo, you will also have the ability to assist the patient with the EMG biofeedback component so the patient can teach themselves to deactivate or relax the hypertonic flexors in order to receive the stimulation and to open up the fingers and release the object. So it's a very nice combination of using the reciprocal EMG trigger stim along with the saboflex.